So many people online. It's great. Yeah, so big thanks to the CTF for setting this up. And I'm seeing lots of new faces, which is also fantastic. So I'm going to talk about treating skin in neurofibromatosis type 1. And hopefully you can see my slideshow here. And it's advancing. All technical problems so far averted. Excellent. So we run a clinic at Royal North Shore Hospital, which is in the north of Sydney, and we started an NF clinic here back in about 2010. Mostly in response to the fact there wasn't an adult service really for NF1 in Sydney. So but we see adults and kids, and over time we were finding that when we were talking to our young adults, they were saying that one of the issues that they were dealing with were their skin related concerns, and that there wasn't really a good place for them to go and have those addressed. And in fact, we did a survey of young adults, and they found that skin issues was their greatest concern of all. You know, despite many people having lots of other medical issues, this was the thing that was bothering them the most. So then we set up a skin clinic. So we got some dermatologists involved, and we've been running that now for almost 10 years. It's interesting, we also recently did a population survey, and thank you to the CTF and to any of you who may have participated in that. So that was an Australian population survey of adults and parents of children. And it was interesting there, 40% of people said that they were interested in cosmetic treatments. And that's for children and adults. So just showing that it is something that's on the minds of people living with NF1. And the other thing that we've seen is we've looked at quality of life measures. There are these survey tools that we use that give us a sense of how much the features of NF are impacting on them and their day-to-day life. And we found that itch and also how visible the features of NF1 have huge impacts on quality of life, and are actually the most contribute the most to quality of life of all of the issues in NF. And that's despite even including things like severity, malignancy, those sorts of, other issues. Itch was actually present in more people than we thought. So half of kids have itch, and adults, more than 2/3 of people have itch. So it is a common problem as well. So our clinic at Royal North Shore, we do mostly treat adults, but we do occasionally treat children. And the big part of our focus is really treating itch and cutaneous neurofibromas. We do also treat scarring and pigmentation, or we're able to do that, but we don't tend to treat cafe au lait macules, and I'll tell you why in a minute. Itch, we've done some surveys to try and find out what people have used, and people have used everything. So it's everyone's given something a go, and I think GPs have lots of things that they try. But what we've found by asking people what's worked for them is that actually the most effective treatments for itch are cool showers, wearing cotton, and avoiding soap, because soap is an irritant, and once you start to get itchy, you get sort of more generalized itch, and that's quite a common feature. Often people will find that that itch starts when they get a new neurofibroma, and then it kind of spreads and affects their other neurofibromas and their other skin. This kind of idea of an itch starting somewhere and then kind of building is quite common. And what we understand is probably the itch is related to the nerve being affected in that neurofibroma. So we all know that NF1 is a nerve tumor problem, and cutaneous neurofibromas, or skin neurofibromas, are just another kind of nerve tumor. They're benign, they don't ever turn nasty or malignant, but that nerve is not functioning properly. So what happens is it may cause pain, or on its way to causing pain, it may cause itch. So that's our understanding of why people itch. If those sort of general things aren't working, There is an oral medication that we can prescribe, and GPs can prescribe this as well. And we have a fact sheet that we can provide GPs if you want to get a local prescription. And it's a medication called doxepin. It's actually an antidepressant medication, but it is used for what we call nerve stabilization at very low doses. And so that's what we use it for. And it's used in treating pain conditions as well. It can cause drowsiness, but that can be really good for sleep. And a lot of people have noticed that their neurofibromas and their skin itches when they're at nighttime often, and can wake them up from sleep. And you can see in this picture here, this is somebody who's been scratching their neurofibromas so much that they bleed. And often we have patients who tell us that they wake up with their sheets bloody because they've been scratching during the night and didn't even know it. There are other medications that can work in a similar way, and they're often in that kind of pain treatment pathway. So Lyrica is one, so people might know that from pain treatment. And then there is another option, which is a type of topical hot pepper, which is called capsaicin. So it's almost like pepper spray, but if you use it on your skin, sort of like using Denka rub and those sorts of things, it stimulates the skin in a different way, so that it takes you're not experiencing the itch, you're kind of overloading the nerves with a different sensation. And so that's another thing that people can try, but you need to be very careful about how and where that goes, because it's not nice if it makes it into your eyes and other places. And this is an example of that quality of life that I was telling you about, these quality of life surveys. And here's a patient who was treated for itch, who had issues you can see all the time. I don't know if you can see my cursor, I'm hoping you can, moving to never for many of those things. So really quite a dramatic impact from starting on doxepin there. So I did just want to talk quickly about treating cafe au lait macules, because they are often the first sign that people see of NF1. And so often when families come to us with children, they're asking, can we treat cafe au lait macules? And because they can be quite visible and they can be a source of teasing at school. So we have looked into it quite significantly. Unfortunately, the type of treatments for this are not very effective. So some people can get a good result. So you can see this person down the bottom has had a good result. It tends to work best on these like irregular bordered cafe au laits, which are not the kind of cafe au laits that most people with NF1 have. They have really smooth bordered ones, and they just don't seem to respond as well. So we haven't really dived into trying much to treat cafe au laits, because we just think the data or the publications, the evidence isn't looking great for it at the moment. And you can see this sort of tracking effect where the whole lesion's been treated by laser. This is called a quick Q switch laser, but you're just sort of getting some areas responding and some not. So that's pretty typical with these. So we haven't moved into it. The other thing is that they tend to fade over time. So usually it's in childhood that they're the most bothersome, and by adulthood most people aren't complaining about them as much. So most of you, I imagine, who are joining may have a few cutaneous neurofibromas. So this is probably not news to you, but it's interesting that we haven't had a lot of natural history studies to tell us what cutaneous neurofibromas do over time. But this is some pictures from quite long follow-up. It's actually 8 years of follow-up. And you can see that they can grow quite slowly, but it's quite unpredictable, and it also depends on the body site. It's kind of hard to know exactly how and predict how big cutaneous neurofibroma will grow. But we do know that they come on over time, and that the peak time of that people notice their cutaneous neurofibroma is growing is in their 20s, and then they can continue to grow into the 40s. We were very early in really trying to understand the different types of cutaneous neurofibromas. And it was only a few years ago that this publication came out. It was actually raised, I think, at the 2018 it's actually the international meeting that we first discussed this, but we hadn't actually tried to classify all of these different types, but you can see how different cutaneous neurofibromas can appear. So sometimes they can be quite flat, and actually you can feel them underneath the skin. Sometimes you can see them on the skin, but they're flat. Sometimes they kind of grow along the skin. Sometimes they're globular and there's a big area underneath the skin, and sometimes they're pedunculated, and which is like a little skin tag. And depending on what the neurofibroma is, we really need to treat them specifically for that neurofibroma. So there are different treatment types for different types of neurofibromas. Let's see if I've got another note. So this one here, for instance, can you see this kind of bluishness that sits underneath the skin? So these we need to treat very differently to a lump like this that maybe we might be able to pick up and snip off. If somebody wants treatment, that might be the simplest thing to do. Whereas something like this actually probably needs an excision and all of the area removed, because if we don't do that, what you end up with is as a big sort of like a floppy space on your skin, which doesn't look good. So each of the different neurofibromas need to be treated differently. And the other thing is that it's often hard for us to say what we're going to do until the day, because we actually need to feel in underneath the neurofibroma and feel how deep we think it goes. And also there's considerations about how hard it is as to whether it will respond to laser or other treatments. There are a lot of groups around the world now thinking about cutaneous neurofibromas. It's actually become quite a hot topic. So we had a cutaneous neurofibroma session at the meeting in 2019. And then there's been quite a few groups who are now looking at whether or not some of the drugs that have been used for other kinds of things like plexiform neurofibromas might actually also work on cutaneous neurofibromas. So the things that could work are things like creams, like a topical application or an ointment. And we've been using topical rapamycin in our clinic for a while. The evidence for that is not fantastic. So we tend to give people a bit of a rundown of what may or may not be possible. But it seems like maybe it holds things at bay, but it's very expensive. And I haven't seen it completely resolve cutaneous neurofibromas. And the topical MEK inhibitors will be interesting, but it's hard to know whether they're going to work for larger lesions. So MEK inhibitors, if you've heard of them, are the things that so that's the FDA approved selumetinib for use in plexiform neurofibromas in childhood, and now TGA approved in Australia, and we're hoping to get it on the PBS. That's the next step. That there isn't really much information about whether that's impacted on people's cutaneous neurofibromas, because that's been used in childhood so far. But that's the next thing, is whether that will work either by putting it as a topical application or by taking it orally. Will it affect cutaneous neurofibromas? But if you know, if you've watched that literature at all, in plexiform neurofibromas, it will reduce the volume of the neurofibroma by 20%. And that's considered a response in about 60 to 70% of people. In some people, it will reduce it more, and in some people, it will reduce it less. But that's what we consider response. And if you think about that in a cutaneous neurofibroma, a 20% volume reduction is not quite so as exciting, I think, as it would be in a large plexiform neurofibroma. So we're yet to see how that will work, but perhaps if they stop them growing, that would be a wonderful outcome, or stop them increasing. Cotodophen's another medication that's being used, but again, almost no evidence, 1 or 2 case reports. and that is a mast cell stabilizer. So it's actually used for asthmatics and allergy. A lot of very old medication, so it's not super expensive like the other ones. But again, because we don't really know if it works, there's only 1 or 2 patients that we've used that for. So then you get into the more traditional types of treatments for cutaneous neurofibromas, and of course cutting them out is something that has been used for a very long time, and electrodessication is the other thing that has been used a lot in NF. And this is a picture of electrodessication. So it actually uses a really, really commonly used surgical tool called a hyfricator, which is the thing that they use to stop blood flow. So if you see things of surgery and you see somebody sizzling and using this cutting tool to sort of cut the edges of a wound and to stop it bleeding, that's the same thing. It's basically just heats. And heats up the neurofibroma and heats up the tissue around it, and then it heals by scarring. So, so this is what it looks like. It's really quick, so you can treat hundreds of neurofibromas in a session, but it definitely scars, and it leaves like a chickenpox scar. And this is some pictures of somebody who's had electrodessication. These are the after photos down the bottom, and you can see that even, and this was 10 months after treatment, you can still see that there's redness. And I've got some more photos. I'll just show you there. This is also the type of chickenpox scarring that you get in electrodessication on the left here. So we have moved over to doing laser, and so we do blade-based for larger lesions, and we use laser for smaller cutaneous neurofibromas. But as I said, these globular bluish ones need to be completely excised by blade-based methods. And we use a YAG laser, and this is a comparison of the YAG laser here, the erbium YAG, and the CO2 laser, which is the older, cheaper kind of laser. So most people who have lasers in their clinics have the CO2, and the super fancy dermatology services will have the YAG laser. CO2 is great, it's super quick, but the problem is that it does burn. It's quite a high heat. So you can see that these spots are actually burnt, and so it causes the same chickenpox scarring as the electrodessication. Whereas the YAG laser uses a much less intense heat. So lasers are just a way of putting energy into tissue or into anything. But the thing about laser is that we can specifically find the wavelength that we want, and and the amount of energy that we want. So it can target a particular part of the tissue, and it can target quite how much energy we deliver. And so that's how we can avoid scarring. So that's why we use the YAG laser. Now I do have another picture, but this includes some treatment photos. So just if you don't want to see treatment photos that may include a little bit of bleeding, now's the time to minimize your screen. I'll just give you a second. But I think if anybody's thinking about having treatment, it's good to know what it looks like. So laser does create a wound, just like any other technique that we use. But what it does is it makes the smallest possible wound you can achieve in treating a neurofibroma. So that's generally what we're trying to do, is to treat the affected tissue and with as little damage to the surrounding tissue as possible. So you can see that when you treat with the CO2 laser, you get burn in all around the tumor, and in the YAG treatment you don't, but you do get bleeding. So it can, it's not as easy. Believe me, if we just did electrodessication and CO2 laser, we would treat so many more neurofibromas, but we wouldn't get the outcomes that we can with the YAG. And this is a picture of a gentleman treated with YAG, and I might have a bigger one, yeah. So you can see that this redness can keep going for quite some time. So this is 5 months after treatment, but 5 years later, you can see that he doesn't have that sort of chickenpox scarring that you get with the other modalities I was talking about. And this is one of our wonderful patients who has allowed us to share her photos, and just showing again that redness. And sometimes that after treatment, the neurofibromas can actually look more obvious because they're red now, and they can be a bit swollen afterwards. So there are other things that we do to try to overcome that after that initial treatment. So this is some pictures of before and after a fractionated laser. So once you've had the actual lumps removed, to make the skin all look one color and one texture, this particular fractionated laser is often used for things like acne scarring, those sorts of things. So you can see this patient had quite a bit of textural difference, and then after fractionated laser, a much smoother appearance. So that we use a combination of tools to try to get the best outcome possible. And this is another nice before and after photo showing that how important it is to try to achieve an overall color and texture, how much difference that can make to a person's appearance. But the other thing that you can see from that photo, oops, if I can go backwards, maybe I can, is that you can see that the effect of lighting is quite dramatic when we're taking photos in NF, and it's very hard to reproduce exactly the same conditions. And so when we show before and afters, often people don't believe us. So now what we're moving towards in our clinic is using 3D imaging. So if you're coming to the clinic at the moment, we're actually doing a research study in combination with the US at Stanford and Paris, and part of that is looking at 3D imaging to show outcomes, to measure the cutaneous neurofibromas before they're treated and after they're treated, so that we can show what we've achieved. And we're using 3 different imaging platforms in the clinic at the moment, trying to work out which one's the best. And this is a picture of a cutaneous neurofibroma that's had some 3D imaging, and you see it, you can work out what the surface area is, and then you can work out the volume and all those sorts of things, which is really powerful for research. And we're now looking at a new study where we're going to be using whole body 3D imaging. So if you come to the clinic soon, that may be something that you'll be asked if you're happy to participate in. We actually have a whole body 3D imaging system just across the road at the health hub, and we're looking to start imaging all our patients over time, because it's very hard for us to sort of talk about what the natural history is of neurofibromas if we're only looking at a tiny spot over time. This will mean that we can look at the whole body, and we can actually answer those questions. What did this neurofibroma look like 2 or 3 years ago, and should we have treated it then, or was it always going to look like this? Those sorts of questions will be really helpful for us. So we run a day stay clinic. We don't use general anaesthetic currently in our practice, so that is something quite significant to consider. So it can be painful treatment, so we often use topical anaesthetic and also injected anaesthetic, and it does limit how much we can do, so we tend to do one region at a time. So that could potentially be a whole face, or actually preferably a forehead or lower face. The other thing that to think about is that people do have wounds, especially for that first week after treatment. And if we're using, so for instance, if we're treating somebody's face with laser, we don't actually put bandages or dressings on, we put on an ointment, but you will look pretty blotchy, and you will have wounds on your face for at least the first week, and then they tend to heal over, and you can start to put makeup or cover up or something on. So yeah, but the patients who get the most out of clinic are motivated. The smaller the cutaneous neurofibromas, the easier to treat. The face is actually, it sounds strange, but it's actually probably the easier place to treat because it heals quickly, actually heals quicker than the rest of the body. But if, for instance, you have lots of large cutaneous neurofibromas, we probably will treat those with a blade-based technique in the clinic. So if you do have access to local dermatology services through your local hospital or some other service, that may save you a lot of traveling time and wait time, because we do have a bit of a waiting list, especially because we were unable to do treatments during COVID in the public hospital system. But we're getting on top of it. We have now actually 3 dermatologists. We've just recruited another dermatologist, so we are moving through our wait list quite quickly. And yeah, also, if you struggle with the idea of pain and treatment whilst awake, that would be another reason to maybe consider another option. And there I'd probably think about going through a plastic surgeon, because plastic surgeons tend to have operating lists. Dermatologists can as well, but it's less common. And I do have some videos. We'll see if they work. Oh, no, okay. I might have to see if I can go down and open it like this. So I don't know if you can see this part of my screen now. Can you see the video? Yep. Okay, let's see if I can get it moving. So this is the fractionated laser. So this just creates lots of little holes in the skin, but then heal over and tighten and become one texture and one color. Okay, and let's see if I can open the other one. And this is the spot treatment. So, oh, has it just gone off? I don't know what you guys can see. I think that one's playing up. Okay, so you can see it's just a different handheld device with the light guiding, and it just goes click and then it's delivered that energy. So if we're treating a cutaneous neurofibroma, there'd be a lot more of that clicking, a lot more of that energy, but it's basically this process. But the clinic is a bit noisy. I might just turn up my volume so you can hear it. But that we have the fans going and the laser's quite noisy as well. So just a heads up. Okay. Put that back up to show and tell. There we go. And these are just some more examples. So this is another, this is a patient treated in the US. And you can see that's a pretty amazing result. And another one of our patients. I think really one of the important things is to think that it's not a one and done type of procedure, that it takes quite a bit. And the patient from America that I showed has had lots of procedures. So this is our clinic. We have two dermatologists who've been working in the clinic for a couple of years, Rebecca Saunderson and Adrian Lim. Sorry, my updated slide for some reason is not here. And Martin Good is our nurse, and Jane Fleming is our research coordinator. And I did just want to, so I'll take questions, but I'm just going to leave this up with a QR code for Tracy Dudding's study. Tracy's talking, I think, at the next meeting. And this is a cutaneous neurofibroma research project